At the outset, I would like to thank the organizers, especially Dr. Partha, Dr. Rashmin, for giving me this opportunity to talk on this topic of OCT in neuroophthalmology. This technique was developed by MIT in United States in early 90s, and it's very similar to ultrasound. And instead of the ultrasound, it uses near infrared light using low coherence interferometry. And the beauty or the power of this technology is that it gives high resolution cross-sectional images and it's non-invasive in a non-contact way. We all know the evolution of this technology from time domain to spectral domain to step source OCT. And with each evolution, the technology it gives us faster images, deeper imaging is possible, and better resolutions are possible. To acquaint you with the machines, we have Cirrus and Spectralis, which are the SD-OCT machines. Atlantis is the step source machine, and Zeiss Plex Elite is the OCT angiography machine. Coming to the OCT neuroophthalmology, the RNFL health can be imaged using the peripapillary retinal nerve fiber layer thickness analysis. We can come to know about the GCC health by looking at the macular ganglion cell inner plexiform layer thickness analysis. And the structure per se of the optic nerve head can be beautifully studied by EDI OCT of the spectral domain OCT or by using the step source OCT. All the segments of the retina can be seen on EDI mode. This is the RNFL, this is the Brooks membrane, and this is the lamina cribrosa. Coming to the OCT protocols, the peripapillary retinal nerve fiber layer thickness analysis is done typically by using circular cross-sectional retina scan, which is obtained at a diameter of 3.4 to 3.5 millimeter, which is centered around the optic nerve head. And this is how it appears on Spectralis SD-OCT, and this is how it appears on the Cirrus HD-OCT. We use Optic Disc Cube 200 into 200 scan on Cirrus OCT. For macular ganglion cell inner plexiform layer thickness analysis, we require retinal layer segmentation, and different machines use different methods. This is how the scan appears on Spectralis, and this is how it appears on the Cirrus machine. And here in Spectralis, we get these two layers, that is the GCC and IP layer thickness separately, whereas in Cirrus, we get it together as a single value. Here it's a circular image, and in case of Cirrus, it's an ellipsoid circle that is studied centered around the macula. I'm not going into the details of how to read these charts of RNFL and GCC. Let's go directly into the clinical application of this technology. The congenital optic disc anomalies have been studied by OCT, and peculiar characteristics have been defined. They can be used as diagnostic adjuncts. Let's look at these cases. So this is a case of optic disc pit, and we have done, as I said initially, if we have to look at the structural defects, then structural problems with the disc, we have to use the SSOCT or EDI OCT. So this is the SSOCT. SSOCT gives a wider scan. You can also look at the macula. Here you can directly see the pit as this, you can see this dark area. This is the pit, and this is, we know it's associated at times with pit maculopathy. Here you can see these skytic spaces. Now, this is a case of optic nerve head coloboma with a disc pit. Here you can see this is the area which has coloboma, and this is the pit. It can be beautifully captured by this technology. This is a case of morning glory syndrome, and here again, using SSOCT, we can see the defect in the left eye, and what we're seeing is basically this is the neurosensory detachment in the peripapillary area. These are forms like defects in the peripapillary area. And this is the glial tissue at the surface. Even the hypoplastic disc can be diagnosed easily on the OCT. You can see a smaller disc area and a smaller cup, and it's associated with thinning of the peripapillary retinal nerve fiber layer. This is the EDI OCT of the hypoplastic disc. Now, coming to this, what is it? Any guesses? It's not a disc. It's, look where the scan is going from. It's the choroidal coloboma. And this is the retinal nerve fiber layer, which is dipping into the colobomatous area. Now, let's move the section through the optic nerve head. And what we get is, we get a nice and big, large cup here. You want to compare it with normal optic nerve head. This is through the normal optic. This is a normal optic nerve head, and this is how it's looking here. So what does the patient have? The patient has glaucomatous optic atrophy. This is a huge, large cup here. But look at the fields. This is not advanced glaucoma. So what is it? This is a case of optic nerve head coloboma, which has been kind of aborted. How do you differentiate from glaucoma? Why do you say it's not an advanced cupping? You see this dark line here on both the sides. This is not seen normally. This is seen in case of coloboma. Now, coming to the OCT in non-calcified drusen's, we published this paper where we claimed that we could directly view the optic nerve head drusen as hyperreflective masses above the RPE. And these are some more images. And we also said that in case of true edema, true papilledema, there was a triangular hyporeflective area. Whereas in case of pseudoedema, we noticed that there was a hyperreflective echo. Instead of this big, large hyporeflective triangular area, we noticed that this area space was filled with this hyperreflective echo, and which at that point we thought was the direct visualization of the drusen. There were many studies at that time which claimed similar things, and there were studies which there was a lot of confusion around the topic. A consortium was formed, and the consortium said that the drusen actually was a hyporeflective area with these superior crinated margins, and it said that to visualize this, you require SDOCT EDI mode, 97 sections, and you can also pick up the autofluorescence in case you're using a spectralis machine. So we looked for it, and we also found the drusen. And what we had, see, this is the drusen defined by the consortium, and this is the discrete lesion which we had initially thought to be the drusen. So what is it? So consortium said that this was actually peripapillary. They termed it as peripapillary hyperreflective ovoid mask-like lesions of forms, and it's a marker of exoplasmic stasis in the optic nerve head. And histologically, they have proven it to be herniating optic nerve fibers. Now, these are the EDI OCT images from spectralis and Cirrus machine showing the drusen. Coming to the clinical use of OCT in neuro-ophthalmology, in acute phase of optic neuritis, be it papillitis, retrobulbar optic neuritis, there is flow stasis, exoplasmic flow stasis, hence swelling of the optic nerve head, which is seen as increased RNFL thickness, peripapillary retinal nerve fiber layer thickness. Over 4 weeks, it becomes thinning. Another finding is that if the optic neuritis is because of MS, temporal thinning is more often seen, and in case of NMO spectrum disorder, you get thinning in the superior and inferior quadrants. Another thing is that this peripapillary retinal nerve fiber layer thickness does not correlate exactly with the visual function of the eye, but MGC-IPL layer gives us idea about the visual acuity or the field changes. The MGC-IPL thinning occurs about 2 weeks later. We said that RNFL thinning occurs around 4 weeks later. And this thinning is more severe in case of NMO spectrum disorder disease. Lastly, we look at the examples of MS optic neuritis and NMO spectrum disorder patients. I said this is a case of acute optic neuritis in right eye. There is increased RNFL thickening you can see here in the right eye. But what we also notice is that the left eye, there is a thinning because of the old attack. Maybe the patient has had a subclinical optic neuritis. And since we have proven here that the patient has had dissemination in time, so this technology can be used to diagnose multiple sclerosis.
Your times.
Yeah, this is my last slide. This is NMO spectrum disorder. As we said initially, the superior and the inferior quadrants are more commonly affected, and this is what was seen in this patient. These are the GCC. I think I'll conclude with this.
Thank you, Dr. Shikha. I think it was a wonderful talk. And I think in neuro-ophthalmology is getting more and more colorful and interesting with these newer gadgets that we are getting, and they are evolving better and better each day. Now that with the adaptive optics, it's going to show us on-fast pictures and showing us much more. So I think as we are in Kolkata virtually, we should say Khela Hobe. So the game is just started beginning for neuro-ophthalmologists.
Thank you, sir. Satya, would you like to?
Yeah, I just have a question for Shikha. So most of the ophthalmologists are, have a particular model of OCT. Traditionally, they bought it 2 years, 4 years, 10 years ago. Do you think the EDI OCT is really necessary for neuro-ophthalmology?
Are those ophthalmologists neuro-ophthalmologists? See, if somebody is coming, somebody is referring a patient or patient's coming you for a neuro-ophthalmology opinion, and you want to really give the best, it's a useful technology.
Okay, so basically the referral neuro-ophthalmologist should have an EDI OCT. That's what you're saying.
Definitely.
Dr. Shikha, I wanted to ask you, the B-scan ultrasound is so effective and cost-effective to pick up a drusen. So that will is an important investigative modality. So how substantiate in the costly?
Sir, we have done ultrasound for all the patients of suspected drusens, and then we started looking for something else when we could not find the drusen, and we did not suspect papilledema. So in a calcified drusen, I agree that ultrasound can pick it up, but the cases where it's a crowded disc and there is a buried drusen, it's difficult to get picked up on an ultrasound. In fact, on OCT also, if you're not following the consortium protocol, you can easily miss it. So if something with such a high resolution is not able to pick it up, then ultrasound may not pick up every buried drusen.